Good morning from San Francisco. Welcome to Musings Under the Moon. Thank you for joining us in community here. Just want to start off by acknowledging the heaviness of what's going on in the world right now. We'll be talking throughout the panel about health equity to our Black and African American audience members, to audience members that have been consistently underserved. I know that you've been holding a lot, and we see your pain. We see that you are hurting. And I'd like to say we are not okay with the status quo. And I want to make sure that I speak from a place of action when I say that. And it's my aim that the whole ecosystem will be able to say that with a lot more conviction than you've heard before. 7 years ago, I started the diaTribe Foundation to give people with diabetes and prediabetes the power of information. Power that, when coupled with the right resources, can transform lives. From the start, diaTribe has been about informing people about the latest and greatest in diabetes innovation. After all, what good is health innovation if it doesn't reach patients' hands? And I'm happy to say that there's a lot more focus now as well on healthcare delivery and how we can do that in a much better way, again, as an ecosystem. And this is what this year's Musings Under the Moon is all about. We want to bring people with diabetes and caregivers, we call them care partners, into the conversations that people across the business landscape are having. This event is typically housed the evening before the ADA scientific sessions. And this year, while of course we are disappointed that we can't gather in person, we have incredible opportunities to make that conversation accessible to so many more people. And we know that by having it in the morning and afternoon throughout the United States, we know that a lot of people are working, have other responsibilities, and we will be able to get everyone replays of the conversation. This is going to be a really, really good one as we get to speak to so many leaders and a young rising star in healthcare who is my co-moderator, Tivia Gopisetti. And I'll introduce them all in a moment. It's been said that 10,000 hours of practice is what makes one an expert in something. I don't know, you can tell us in chat in the audience if you think that's right. But if that is the case, then people with diabetes, the experts, obviously you all need to be part of these conversations about innovation. You need to continue to be part of them. You've been a part of them in the past and need to be making sure that that all of the patients are in from the very beginning. And I think that so many of the leaders are really striving to make that happen in an even more intentional and deliberate way. That's also one reason that we're really thrilled to have you here today. We encourage you to use the chat on the side to ask questions, to share your thoughts, and really, share your thoughts with the panelists and with the other audience members. This is a community event, and we're really, really keen to learn from each other. COVID-19 has made me feel stuck and helpless in many ways. And it's also made me feel hopeful. We're in the process of rebuilding so many systems that for so long have been fragmented. The law of inertia tells us that what's in motion stays in motion, and what's at rest stays at rest. Today, we want to consider this law in the diabetes field. What needs to happen that isn't? COVID-19 is giving us an opportunity to reevaluate what's working and what's not working across healthcare design and delivery. The status quo is simply not enough for people living with diabetes. And it shouldn't take a global pandemic for us to think again as deliberately and intentionally about that. But we are, and how can we all talk about it and move toward driving forward to a new, much better environment? And I don't know that new normal is really the phrase that I want to use because there was so much wrong with the old normal. But how can it be made better? And how can we think about it really from a multi-stakeholder perspective? We've seen CMS step up for lower cost insulin and CGM access and work with many manufacturers to make that happen. Those are some amazing partnerships that wouldn't necessarily have been envisioned before the pandemic. We've seen virtual coaching give more patients the information and tools they need to better manage their diabetes. And there are just so many more opportunities that courageous thinking can propel. And we want you to think big and bold while you hear from our panelists today. What is the future of diabetes care that we want to continue in, that we want our kids to grow up in if we have children, that we want our parents to experience, that we want every part of the community to experience? Today, it's amazing to have so many different people from such an expanded field with us, again, this morning, afternoon, evening, depending on where you're tuning in from, or depending on where you're listening from, if you're on this later. So before we get started, just a few reminders for those with us live. This is exciting for us at diaTribe that we're on the new Hopin platform. Please use the chat, again, on the right-hand side of the screen to communicate with us. And if you have a question you'd like us to ask the speakers during the audience Q&A, or if you experience some sort of technical issue, or if you want to make a comment about the content of the discussion, and I hope we see a lot of that, please feel free to use the chat. Remember that if you write something in the chat, it will be seen by everybody who's watching the event. So please, it goes without saying, be respectful and courteous. At the top of the chat window, you'll also see a tab for polls. We'll post questions right throughout the event. Go ahead and try it out right now. Let us know where you're tuning in from and what your relationship to diabetes is. Can't stay for the whole discussion. Again, it's being recorded right now and it'll be circulated to our diaTribe readers. Please sign up at diatribe.org/join if you're not on the list. Our incredible community manager, Cherie Shockley, will be live tweeting throughout the panel at #diaTribe Musings. Please join the conversation on social media if you'd like. That's at Facebook, Instagram, and on Twitter. I think she'll be on Twitter most of the time. You may have seen the pictures circling about our incredible speakers. Their social media accounts or those from their organizations are easy to find if you go to diaTribe News, which is our own handle. And as always, I would like to thank so much our sponsors who have made this possible. If we were together in person, their names would be up in lights. Thank you to our gold sponsors, Abbott, AstraZeneca, and OneDrop, our silver sponsors, Dexcom and Sanofi, and our bronze sponsors, Insulet, Lilly, Medtronic, and Novo Nordisk. It means the world to us what you are making possible to us as a nonprofit. We're going out to almost 250,000 people every week. Thank you so much for your help in growing that number. And of course, thank you to diaTribe for turning on a dime and making what I know will be a set of really compelling remarks possible. This afternoon, this morning, this evening, again, wherever you're listening from and whatever time zone you're in. And without further ado, I'm really thrilled to welcome the following leaders whom I regard as some of the best thinkers in the diabetes field. And I'm going to say a little bit about them once they're on the screen. But first I'll say, first up, Sanofi's Chris Boulton. Next, AstraZeneca's Kiersten Combs. And next, Medtronic's Salmon. And finally, my co-moderator and amazing colleague, Divya Gopasetti, who I think now is about 65 days from entering medical school. And she's a co-moderator today, but also I'm going to be asking for her views on so much as well. I wanted to start, before we get into the questions, I just wanted to say a little bit about, about your organizations. I guess that includes Divya. I'm so happy to have her here with me co-moderating. She joined us for the summer at Close Concerns 3 summers ago, and then we were very lucky once she finished human biology at Stanford. We were so lucky to have her come to diaTribe, and she's just finishing 2 years. I guess it was 2 years ago now that we were at your graduation. And it's a very different world right now, and this is providing, but the changes are really providing a reset. I want to say thank you to our whole diaTribe team, and also for everybody who is starting their generation is amazing, as all of you know, the best I've read about, thought about, studied, and for all of them to be as focused as possible on the world's biggest health problem of diabetes is a privilege for me to work with them. I want to say some things about the companies before we start, and I'm going to start with Sanofi. Chris, I remember the moment when you guys made basal insulin. I think at the time it was a predecessor company, Aventis. That changed so many lives for all of us. I had been in the emergency room for severe hypoglycemia 24 times. And then I started being able to use an analog insulin, very lucky, bringing so much more stability to me. And that changed my life. And I want everybody to get it. And I just totally salute you for all of the patient access programs you're creating. Not only can people get Lantus insulin, they can get Toujeo, like the very best of the best. And I don't know if everybody knows about all of those programs, but it's amazing to see. You have a long history of really working with primary care. I wanted to talk a little bit about AstraZeneca next. It was amazing to see you buy Amylin, which was a company that was close to a lot of our hearts, and to really say you were going into diabetes in a big way, and to say the status quo doesn't need to be the way it is. We would like to see many fewer people with type 2 diabetes have to take sulfonylureas, because we know they cause hypoglycemia, they cause weight gain, and for you guys to say we're going into this field and we're going after using medicines very early in disease progression that don't cause hypoglycemia and that don't cause weight gain, that are so much more stable. And the fact that you invested in those because you also saw something that was really special. You saw something that meant that all of the people with type 2 diabetes for right now didn't need to be at such high risk of cardiovascular disease. And that was a seminal moment when you did that. Thank you so much. And it has been amazing to see you have trials stop because it was actually considered dangerous for people to continue on some of that therapy. I hope that there is a way that we can help get the word out to people that complications are not inevitable, and that there are so many things we can do differently, and that progressive disease doesn't always have to be associated with type 2 diabetes. And the last thing that I wanted to say a few words about Medtronic. I remember the moment that Medtronic bought MiniMed Diabetes, and it was almost before most of our associates were even born. Maybe a few of them were toddlers or in preschool. That was an amazing moment to say that you were investing in Al Mann and in his just legendary commitment to innovation. I remember the moment, Sean, and I wonder what it was like at Medtronic. You have led so many different businesses, really successful businesses at Medtronic, and I'm so happy that you're running Medtronic Diabetes now. But that moment when the 670G was approved, that speed in which FDA got us there, because they wanted to start off, automating insulin delivery, and to see that get approved so quickly, and to see them have a press conference about that. I don't think we've ever actually seen that again in diabetes. But the idea of automating insulin delivery again for patients is very, very exciting. And I know that Medtronic is thinking about doing that in a bunch of different ways. Chris comes out of integrated care at Sanofi. And there's so many ways, like you're reducing barriers, you're making it easier and better. And that doesn't necessarily, those are not necessarily words that have typically gone together in diabetes. So I just wanted to say a little bit about your companies. And now I'm going to go into the first question. We're going to go in to start talking about health equity, and just to say, we've known for a long time that low-income communities of color are hit the hardest by diabetes and COVID-19. And again, we also see so many communities that could really benefit from some of the innovation that I was just talking about, and some of them have, and not enough. So I just wanted to start out and just say, in the midst of all of this heaviness, how are all of you doing? And I want to start with Divya as an incoming medical student, again, 65 days away from entering, from your classmates meeting you. How are you? What emerging needs of the moment do you hope to see addressed?
Thank you so much, Kelly, for the lovely introduction. And I want to start by saying that I am so honored to be among this esteemed panel on the virtual stage today. And thank you so much to everyone who's tuning in. In terms of how am I, this has been a hard week. I continue to have a heavy heart as we all mourn the tragic death of George Floyd and many, many others. And in that vein, I've been thinking a lot about how there's two big pandemics that are in the spotlight. One is COVID-19 and one is racism, and both affect Black communities disproportionately. And I think we've seen many examples about how the structures that we have in place are fragmented. But I've been feeling hopeful recently about what's possible when the whole world is aligned towards the same goal. So just to address the second part of your question, with diabetes and an emerging need, I want to see us act across sectors with a lot of different voices represented, including patients who are the diabetes experts. And as an incoming medical student, I want to see us all designing solutions for the most underserved, the most underrepresented, who are also too often the most impacted by adverse health outcomes.
Yeah, I mean, from your lips, Divya, you know, I know also if more of that started to happen, that would be called investment, and I would love to see more investment. Going back to just hearing from all of you and you, your teams, your families, Kiersten, we'll go to you next. How you're doing and what emerging need would you like to see most addressed?
Yeah, I think like Divya, you know, it's been a very hard week on top of a very long quarantine, and where you think things are just about to get better. You know, I think what has been put in front of our face, and as a nation, that discrimination and racism is still a huge reality for our African American community members, but really us as a nation, and diversity continuing to be a hot topic of discussion that I think in some cases we probably thought as a nation we had addressed. Clearly, there is a lot more for us to do. And that shows up in a lot of different ways. As Divya says, it shows up in how patients are treated, how healthcare is delivered. But I think even more importantly, it also, which has been quite humbling for me, shows up in corporate America and how our teams show up at work, what we can do as a large organization with team members in all sorts of communities from all walks of life, really with the mission of helping save lives. You know, there's clearly more that we need to do, that I need to do as a citizen of the United States, but I think also more broadly as a healthcare industry. So I think that has been, that if there is a silver lining, the humility of the week and the learning on what I can do to affect change and be a force for good has been what I take out of the week. I think that, like Divya, and we saw this with COVID-19. When COVID-19 came, we saw an accelerated change into things like telehealth and virtual healthcare that we have been talking about for a while, but all of a sudden, as an industry, as a nation, we were able to make it happen. I'm very hopeful that we will see the same type of accelerated change coming out of the protests and the death of George Floyd this week.
Yeah, thank you. And Chris, to you, your views on the biggest emerging needs at the moment, and how are you?
Thank you, Kelly. Personally, I'm well, thank you. Like everyone, shocked and saddened by the scenes we saw this week. But I hope from this we have some reminders of the good as well, because fundamentally this world is full of good people, and we can see that reaction as well. And what good people need to do now is take more action. We need to be more vocal. And whether it's in our workplace or in society, we need to take more of an action as well. So I think this is a message for all of us. We can do more, and by having these conversations is exactly the right place to start. On diabetes and COVID overall, you know, clearly, like everyone, alarmed when we saw some of the data on the incidence of diabetes, on the severity, and of course the populations that were hit the worst with this overall. And again, you know, from my own perspective, with a daughter with diabetes, this has been try not to panic. And I think this is important. We understand the situation. We have to control what we can control, which is doing the right things around our medicines and our treatment, and actually being safe and shielding people. But I think the most important thing for the diabetes community is to do what we do, which is stay positive. You can worry yourself about lots of things, but actually the most important thing is to have the right mindset and think overall, look, we'll do the right thing and we'll do what we can. So that's a little bit how I'm feeling at the moment.
Yeah, and to see what your mindset is and the mindsets of all of the leaders is encouraging. Sean, handing it off to you.
Yeah, thanks, Kelly. I think everybody's expressed a lot of the first reactions to this. I guess mine's this combination of just horror and shock and increasingly awe. To see this horrific killing of George Floyd and the pain that has provoked in so many, and to feel how this kind of crying need to how can I jump out and help, and how can I do that, and that help, that's also personal, right? How can you contribute to change, positive change, and that's the awe-inspiring part. I mean, to see the global uprise and protest and engagement, see my own kids. We're having these conversations that are so important, and to lend that support there. And our team members have just been amazing too. People are hurting right now. People are motivated right now, and they have been through this whole pandemic. The way work has changed, the way life has changed, and to see that resilience and the caring attitudes of people to just persevere through all their personal and wider societal challenges. But I think you said it well, Kelly. It brings in sharp relief how much inequity there is in this world, and it plays out in healthcare, in education, housing, opportunity, and in life. How people experience that. So it's been a heavy week, and it's also been a hopeful week, and it can't end with this week. I feel a call to action, all of us do, to make sure that we show up and bring our best selves every day. And within what I can control, I want to make the place that we work safe, inclusive, and empowering, and that's a place I can have an immediate impact. And outside the walls of what we do in our business, of course, that's what we're all about, trying to make an impact and positively help people around the world.
Yeah, so well said, all of you. Thank you. And a hard week and a hard set of months and a hard history. And, the disparities that we see, they're exacerbated, obviously, with COVID-19. Some of the region-specific data we see from Chicago, my brother lives, the other day showed 90% of those hospitalized with COVID-19 have chronic health conditions. And, 70% of those with COVID-19 were either people of color, people with diabetes, or both. So I wanted to ask you guys some questions about the equity front, and I'm going to do it like this. Kiersten, I'd like you to go first, and I just want to know first, what role does prevention have on the equity front, and then we'll move to Chris and ask what role education has on the equity front, and Sean, what role technology has. And over to you to start, Kiersten.
Just want to make sure I took myself off mute. So I think your stats are really kind of sobering. And there was another statistic that I read also, that you look at people who have died with COVID-19, the two top comorbidities were hypertension and diabetes, two diseases that impact the African-American population at a greater rate than the rest of the nation. And so when you think about that, you ask, well, why is that? And so I think it's both about prevention as well as treatment. But if you start with prevention specifically, it starts with screening. But it starts with education, it starts with screening, and then it starts with treatment. And once you can then keep your disease at bay and in control, then you have an opportunity for your body to be able to fight off additional disease. And so I think when you talk about what it means to be able to screen underrepresented populations or lower socioeconomic populations, there's a huge need across our country to be able to do that. I think it's something that while we often talk about, we have a very hard time actually mobilizing, because I think it's often not a national type of program, but it is something that needs to be done at the local level. And it's embedded not only in kind of community outreach, but also kind of cultural norms and mores on how different communities and different populations see healthcare as part of their daily lives.
Yeah, and about probably like, how do patients think about what do we deserve? Yeah, I think also even just having treatment that, again, actually prevents heart failure or prevents cardiovascular disease or prevents kidney disease. We're not really used to thinking about it in such a proactive, actionable way as that. But it does take education. And yeah, Chris, I just want to go to you next. You've got a company that has, again, such a long history of educating, especially primary care doctors who are kind of their own embattled population in different ways also. So tell us what you think.
So as a diabetes community, we are all used to coming together and talking about better education, right? And, but this is a group of people who are very knowledgeable, are very curious. And, next week is the ADA, and normally we come together and talk about all the, the latest ideas, time in range, technology, etc. And we get very enthused and want to share that. But here we're talking about a different form of education. And it's about taking education to the people who need it most, and making sure we do what we can, as Kiersten said, to screen and help the populations underserved and most at risk. And Kelly, I want to be specific about a program I read about. I've not been in the US business so long, but I was very intrigued by a program Sanofi collaborated with the National Minority Quality Forum, where what they did, they went in to some underserved populations. And sometimes, the ideas are simple ones. It's actually bringing two principles together. One, looking at better immunization for flu. And of course, we know some of the links again around flu and diabetes, and some of the challenges there. But then also use that chance for education and working between the health system, the community, and the HCP, taking that time to do some primary screening at that point and really focus on diabetes and broader chronic conditions. 3 pilots went ahead last year with good results, increase in immunization rates, and these programs are looking to go more broadly. So again, I think there are many, everyone will have examples of this, but again, this is a great example of, this is about doing the right thing, making sure we do what we can when there is so much to solve for, picking areas of highest risk where we do need to intervene. And that's how I want to frame education a little bit differently to the education that we are very used to from a scientific education perspective.
Yeah, thank you. It is amazing to see all of the focus on that work of Gary Puckering, Dr. Gary Puckering, who has just been seminal. And so we're hoping to get back to some of that later in the conversation. But I want to move to Sean and ask what you think about the role of technology on the health equity front.
Yeah, well, technology is a big world, right? You think about where are the inequities, and the inequities of access, of health literacy and education, and even trust in the healthcare system, and how do you transcend all of that? I agree with Chris. I mean, getting to education awareness is really critical. And in our world, we're kind of in this automated insulin delivery kind of bubble that we live in. And even within those who use insulin, only 1 in 5 patients even knows who Medtronic is. That's really kind of amazing that that's there. But things like social media and education vehicles are great. And maybe we'll talk some more about this, but the idea that you can use technology also to change the care delivery model. There's not a great endocrinologist available to everybody, everywhere, but there could be. And you can really multiply that access in a way that leverages connectivity, that part of technology. Within the space that we're in, CGM has been really revolutionary for patients where, they get this window into their disease, this insight into disease, and they get to experience, what is it that's affecting me, and how can I be aware of what I eat, what I do, what stresses in my life are affecting me. And sometimes it's frustrating, and sometimes it's illuminating, or for a parent taking care of a child with diabetes. So that's great, and we endeavor to take that worry away, of course, by having technologies that just work and can help manage all of the decision making and the challenges that plague patients. But access to that, as I said at the outset, is really what is critical. knowledge, awareness, and affordability.
Yeah, knowledge, awareness, and affordability. That's a lot. I love how you talked about CGM. It reminds me back in the day, Jennifer Hahamian, who is, a leader and advocate in the field that many people know, said, like, you guys, like, patients need to know where we are before we can figure out where we're going to go. And there's so many more exciting places for us to go now because of everything that has been invented. And I just say, like, everyone needs to have access to CGM. By handing it over to Divya.
Yeah, building off of that, thank you all so much for speaking the truth. If you go to the second tab next to the chat, you can see the polls. And here today we have about 40% of our audience are people living with diabetes. And we're grateful that our leaders can really just speak the truth of people living with the condition. So building off of the conversation around access, and that's access to care, therapy, technology, food security, housing security, like Kelly just said, we consider continuous glucose monitoring to be the keys to the kingdom of better diabetes management. So on that note, we have 3 new polls that are about to be launched. So we'd love for you to answer those. And Sean, we'd love if you could talk a little bit about what you think CGM can do to change the game.
Yeah, so I think there's so much that can and already has happened with CGM, creating that window, as you say, into people's disease. But what you want to know really in CGM is what's going to happen to me. And that's what's happening to me right now. And I think the next step for us is to, no matter how you're getting your insulin, to be able to, or you're not using insulin yet, to be able to kind of give you some predictions about that. And we leverage data science, a fancy way of saying just how we can take big sets of data and predict what's going to be happening in the future. Are you going to go high? Do you need to take insulin now? Will you stack it and then chase a low on the other end? How do you know to correct well before you get into that low state? And to get better and better and better at that, or even insights like, I want to go exercise, and do I need to take some carbs, and how much do I need to take? That really is going to take the power of what's feeding through that CGM device and turn it into actionable insights, information that can help you just kind of live a smoother existence, right? And that's exciting. There's a lot that we're going to be working on to deliver on that more predictive and preventive world, to augment where we are already, with just being able to know, after the fact what happened to me and try to understand why to prevent it.
Great to hear, Sean. So I've just spent a year working in the technology space at Sanofi, and I wouldn't consider myself a real technology person, but it's great to experience and learn a bit about this. And because I come from sort of a broader background, I always put 2 things together. Yes, you want the shiny thing, you want the next great piece of technology, but it's got to be accessible, and you've got to be able to scale it, and you've got to be able to support it and maintain it, and making sure you can move it on from something that just goes to a group of very motivated early adopters, something that the early majority can get to. And I think there's great data to show that you can get a group of people around something very easily, but then will it stick? And I think that was always on my mind, and is still on my mind when we think about, I'm sure we'll share some nice ideas of things we can do over the next 5 years in diabetes, but how do we bring that through in the way we have with devices and medicines in the past? So that comes with the cost side of affordability, but also a logistical part of that as well.
So the only thing that I would add, and it's a bit of an evolution of what we're talking about, but I think while glycemic control is very important, specifically if you look at the type 2 diabetes population, in which we spend a lot of time focused on, glycemic control is important. But Kelly, you mentioned in the beginning around prevention and protection, and you look at some of the new medicines that are on the market, the new science today, specifically for type 2 diabetes, and you are able to not only deliver glycemic control, but also there's quite a shift into cardiovascular protection, cardiovascular renal protection. And I think that for diabetes patients, that's a huge advancement in not only being able, really looking at both the micro as well as the macular vascular issues that patients suffer from.
Yeah, I just think of it as a bonus for patients. I mean, my God, like to be able to, again, kind of about deserving, but to have medicine that is actually working on all of that stuff is just very different from how it has been historically.
Yeah, and Kiersten, building off of that, we talk a lot about the idea of shifting from reactive care to proactive and predictive and preventative care. How do you think that the current environment in light of COVID-19 has changed this shift for either better or for worse?
Yeah, well, I think it's probably kind of a combination of a couple things. One is that the science is evolving, so you can treat your diabetes in a more proactive way. But you also see it kind of goes back to the last conversation. It's about education and patient activation, right? Because unless you actually are going to the doctor and you're diagnosed with diabetes and you are on a medicine of some type, then none of this you don't even start on the journey to be able to protect or prevent progression of disease. I think what you see with the science is that there are some really innovative medicines out there that provide more protection, but you still look at the amount of diabetes patients who take those new medicines today, it's probably less than 10% are on a GLP-1 or an SGLT2. So Kelly, you started in the beginning around the amount of patients that still take SUs. It's significant, right? And I think that this goes to the piece around patient activation. And the piece that worries me most about the environment we're in with COVID-19 is that we've seen patients not go to their doctors, right? It's let alone not go to the hospital because people are very scared about going to the hospital, but people are not necessarily going and doing the regular checkups and maintenance on their current underlying disease like diabetes that we've seen in the past. And so I think for us as an organization and really us as an industry is how do we start to provide healthcare to folks, which is why I'm so excited about telehealth, right? Because there are ways to actually be able to have that type of healthcare. Sean, you talked about it, right? Endos are a great example. There's just not enough endocrinologists to meet with all of the patients who have diabetes today. But is there a way in a virtual world where there's actually more access to specialists than less? Like that could be a very exciting tomorrow for us.
Yeah, I agree, Kiersten, and I think if you think about that, what we can unlock with telemedicine, right? A patient has to move from doctor to doctor to appointment to appointment, and it's disruptive to their life, right? And you can imagine this world where maybe there's more on that patient and the connection for that patient between their heart doctor, their foot doctor, their eye doctor gets a little more connected, right? And that's not how medicine is, right? These silos and domains of surgery, medicine, and those connection points, collaboration, you can see a future that could be really exciting about it to deliver more value with the care that people are getting. But it's aspirational. You need the incentives to align, and that's been constraints.
So let me build on your point, Sean. I think on top of telemedicine, I think there's something else we're fortunate to have in the diabetes space is good virtual diabetes clinics, tools that we can access and enroll HCPs and patients. And again, many of our friends in the community work on these and maybe on the call. So again, I think this is something I always think disruption drives innovation, and when we've been disrupted. So I hope this accelerates our adoption of new approaches. And I've seen some data that by having a virtual interaction between an HCP and a patient, actually it can be a richer conversation on the condition itself because it takes away a lot of the background noise of all the other things going on in the office in the meeting room. So I think there's a lot we can learn. Hopefully we get to this point where we find the best of both. But for sure, I think this is a little bit where technology that's already out there we can further utilize to improve everyone's experience, the person with diabetes and the HCP and how they manage their broad practice. As you say, when there are more and more people living with diabetes and no more HCPs to manage this.
Yeah, it's been really amazing. We've been learning a lot more about telemedicine. I'm back at diaTribe, the Helmsley Charitable Trust, who we are so lucky to be funded by, has done so much early investment in telehealth, going way back. And all you need to go to do is go to their website and see some of the work on Echo. Stanford is doing a lot on this, having many doctors also gather together, and the learning online and all of that has been great to see and great to take them back. We just got a text from Ann Peters. She said actually today there's not as many, she's actually said a lot of patients are back at work today. And so just to speak to that part of the crisis, we know that telehealth has also helped a lot of patients in that way, be more efficient. And we want to make sure also that there is support for the hospitals and, all the hospital-based practices. But Divya, you're going to be going to learn in the hospital for the next few years. What do you think about that predictive and preventative and all of that as we think about driving forward what change can happen?
Mm-hmm. I would love to reiterate, Kelly, what you said earlier about how diabetes complications do not have to be destiny. Diabetes does not have to be progressive. And that power lies within patient hands. And so I would encourage people to remember that lens and remember to work in partnership with patients as much as possible to really remember that health exists outside of that 15-minute clinic appointment. And yeah, like your patient goals should be your goals. And I think that frame of prevention is critical to a better future of health.
Yeah, absolutely. And the patients can do it if there is the alignment that is set up from the payers. And we know how important this is globally, and especially in not a single payer system like the United States, but just related to prioritizing prevention for Kiersten and Sean in particular. Currently our healthcare system isn't really set up to reimburse and motivate the best care yet. And how do you see the movement toward value-based care changing as a result of the current environment?
Sure. So I'll start, Chris, and then maybe I'll throw it to you, because as I was sitting here listening to the conversation around, and Divya, what you just said around the patients really kind of needing to be more active in this, especially as we move into more of a virtual telehealth world. I think that is very, very true. And just to share a short story of my experience during COVID is my mother was hospitalized with some health issues for a short period of time. And, I do find telehealth that I'm now her primary caregiver or care partner. It's quite convenient. I can do it like in the middle of like I can schedule a meeting and I've got 20 minutes and we've talked to all sorts of cardiologists and hematologists and primary care, like all of our doctors, and we haven't even left my house. It's very convenient. On the other hand, if my mom didn't have me, she would not be able to do it. Every system's different, right? She has to download different applications. She gets very, very nervous about talking to doctors, and they're asking for blood pressure and things she doesn't even have available to her. So I think the point is that to have an integrated system, it's got to be much more patient-centered, because our entire population is getting older, like my mother. And while it's very convenient for me to, be able to do the telehealth, it's very intimidating for her. So I think we've got to fix that part on how it becomes much more user-friendly for a population of individuals who didn't grow up with the technology that I would say my 14-year-old probably could actually take care of the entire telehealth and go pick up her prescription and have it delivered somehow already by herself much better than I could. The second piece of it, though, is that the way that healthcare is reimbursed is also not necessarily incented on prevention. So we spend a lot of time at AstraZeneca talking to partners around how do we prevent disease, and how does that become the right business model for an integrated health system? And the integrated health systems are the ones who have potentially a healthcare plan plus a hospital plus a bunch of primary care organizations. They're the ones that say, okay, I can see if we can reduce the cost of care overall, that we have less sick patients, then there is a better business model for me in that. But the way that we're bifurcated today between the insurance companies, the hospitals, the primary care clinics, the government, like the way that healthcare is reimbursed, until we fundamentally change it from a point in time reimbursement for a healthcare visit to more of this patient's living longer with less disease, I think we won't make much progress.
Yeah, that is so right on. I wanna say Sean has so much experience, and Medtronic has so much experience in leading with value-based care. I want to move right over to him. But just one other thing I want to say, Kiersten, like the whole thing about mom and telehealth and all of that. It is right now, but we really hope that it'll change in the future, and we see it changing. Andrina Milan Farrow is this amazing dietitian at the Joslin Clinic. She made for diaTribe an amazing video. If you just use any search engine to go to YouTube and the diaTribe Foundation, she serves as the patient education and research coordinator at the Latino Diabetes Initiative there. She helps so many patients, and I think that the power of what can happen, that is what will lead to the learning and the long-term value and investment that I know all of you care about so much. But Sean, yeah, over to you.
Yeah, Kelly, you're right. We've spent a lot of time trying to think through, how do we change, and how can we be a part of that change? It moves from kind of being paid for what you do to being, do to patients, and being paid for what you do for patients, right? And what is that outcome that you go to? And I think the sentiment is really easy to understand. And Kiersten so well articulated the challenges, right, about incentive alignment. This time, can I get my return on my investment right now, and how that coordination works? Value is something you can measure, right? And it's also hard to measure. And depending on the field you're in, how do you value that? And who's winning in that value? Are you avoiding cost? That's a huge part of the value. But are you doing that without trading off quality, where quality gets better when there is access and people can get to that? So that kind of those dimensions of that. And I worked through this in a number of different places, including like this bundled payment initiative, where you would kind of take responsibility for not only the episode of care up front, but how well was that patient managed for 90 days afterwards, and being responsible for those costs. And there was some interesting experiments that were done. We did it in heart valves. We did it in revascularization for coronary disease, both by surgery and by intervention. And it was done in the orthopedic space. And what was interesting in orthopedics was there was this other unintended consequence of the system, right? Where the very best surgeons were avoiding treating patients that might be too unpredictable or uncostly. And they were kind of cherry picking and treating the easier to treat patients. That left patients underserved and left them in the hands of maybe a less experienced surgeon who didn't get the great outcomes. So that benefit wasn't there. So I think as we're redesigning a healthcare delivery system and the incentives that go along with that, we have to be mindful of those unintended consequences. Your question around prevention of care, can you get a return in the time window that somebody's budget exists? Within diabetes, we're trying to avoid, this is preventative care, right? For what my part of the contribution we're trying to make, to avoid those complications, as you said, don't need to be inevitable. Mm-hmm. But we have the near-term benefit of keeping people out of the emergency room. So it's a little different. We've got a little bit of different thing than maybe when I was working in hypertension. You're trying to avoid something happening to a patient 10, 20 years down the road, and you need somebody to pay for that today, right? And it's complicated, but the mindset is changing, and that's important. We just got to get the metrics right.
Yeah, I wonder how many healthcare economists all of you have connections to. I guess it's so cool, hard cold data about what can change in the long term that will, that I think will enable more reimbursement upfront. And actually, we just had a question from the audience that is along these lines, and this was, should all people with type 2 diabetes be taking something like an SGLT2 for its cardiorenal effects? And I guess more broadly, can Kiersten, and if anyone else wants to jump in, we're going to be getting plenty more audience questions as well. So thank you for this. But can you talk about the role of diabetes medication in terms of prevention? Also, what it would take to get everyone with type 2 starting on the right medicine and then moving toward the right medicine. There's also combinations out there, insulin, basal, GLP-1, all of that. So yeah, any comments on that? Thank you for that question. Oh, I think you're.
I just smile because boy, I would love that to be the case, right? But I think, look, the reality of the situation is that I think the SGLT2 class of medicines, the GLP-1 class of medicines, are great innovations that can help treat patients' type 2 diabetes, but also provide cardiovascular benefit to them. And what we hope to see in the future is renal benefit also. The cool thing about what you're seeing in the SGLT2 class is that, yes, right now, most of them are approved in the type 2 diabetes population, but not to plug my own medicine, but Farxiga is the first SGLT2 who's now approved in treatment of heart failure outside of type 2 diabetes. So if you talk to anybody who is familiar with these molecules in this class of medicine, there's true hope that, it's not just about treating diabetes with cardiovascular renal benefit, but there is an opportunity to treat this patient and provide cardiorenal protection to them with medicines like the SGLT2s, and specifically a medicine like Farxiga. So I think whether every patient should be on look, that is a decision between a patient and a doctor. But what I think is really extremely exciting on behalf of AstraZeneca, on behalf of all of us who are in the diabetes space, is that you're starting to see the convergence of these disease areas in treatments that actually kind of treat a holistic cardiovascular, metabolic, renal patient, because these comorbidities are significantly overlapped. So whether you have diabetes and a comorbidity like cardiovascular disease or CKD, there's a medicine for you. If you just have CKD or heart failure, there is also going to be opportunities for you in that space. And that's the exciting piece about following the science and really trying to put the patient at the center. I think there's a tremendous future for patients in this area.
I could add a couple more perspectives here overall. I followed the science on SGLT2 and GLP-1s and the data, and for sure this is wonderful progress for the community. A couple of other points around good use of medicines, just to flag overall. I think one is about treatment inertia. We know the way this disease area has been managed over time is try a medicine and then wait 6 months and then see how we do. And of course, we're always playing catch up in that setting, and that applies to any medicine from metformin in type 2 onwards. So again, there's so much we can do with existing medicines, to use them at the right time in the right patient and not always hold them back overall. And that goes all the way through until the choices around insulins and even fixed ratio combinations at that point in time. The second point I'd like to make is actually how we think about when we should use medicines differently. And we think about type 1, and indeed, people on insulin in type 2, around the use of markers such as time in range. And again, yes, we know the establishment of A1C and the importance of A1C. But again, I know from my own life, the measure for us is every minute of every day and time in range. And it is frustrating when, as a patient or a caregiver, you have to spend your time justifying why time in range is important when you know it is the measure on a day-by-day, 24/7 basis. So for me, greater acknowledgement of that. And indeed, now we have medicines and, of course, devices that help improve time in range with great results, as well as, of course, the all-important A1C test. We need to take this more holistic picture of the quality of glucose control, as well as that one measure. And again, again, at Sanofi, we do a lot around time in range. And of course, with the CGM, there's so much more we can do to better understand the condition by utilizing CGM in that space.
Thank you, Chris. We got an amazing question from the audience around the role of the food system, both in terms of prevention and in terms of improving things like time and range. And that's from Paul Fernandez, right here in the Bay Area. And so I'd love to talk, well, first of all, food system, we can't talk about prevention without talking about food. And that's partly why we had a session called Food as Medicine prior to this event, and that room will be open afterwards as well. But on that note, there's so many uncommon partnerships that we'd like to see happen to better diabetes care. So we'd love to hear from the panelists, maybe starting with Kiersten. what are partnerships that you hope to see happen or that you already see within your organization?
Divya, you mean from a food perspective, or you just mean overall kind of innovative partnerships?
It could be food related, but I think in general there's so many systems that need to align incentives. So
yeah, because maybe I'll take it just a bit broader, because I think that well partnerships, and I saw a lot of questions on the chats around diabetes educators too, right? And I think that also kind of, it goes hand in hand as to how do you actually make the lifestyle modifications, the food choices that you need to kind of control your disease. And I think those are really important areas to focus on. And, I think this is where, specifically as a large manufacturer, you also got to be real clear as to what is the role you play in the solution. And so I think from our perspective, we spend a lot of time thinking about how do we support primary care HCPs, and what does that education look like, and how do we help diabetes educators who are working with patients to provide them the right education and the right resources. So I think that's a really important component to this ecosystem. But I also think it's broader. I think that elevating, if you think about the amount of people who either have diabetes in this country or pre-diabetes, it's a pandemic in of itself, right? And so like elevating that conversation, I think is extremely important. So partnerships between industry, academia, and advocacy, I think is the only way you can do it. We can't do it alone. These types of forums are extremely important. Partnerships with academia on how we are advancing the science and what that can look like, not only from a molecule perspective in the medicine you take, but, really around implementation science. How do people get the right type of care at the point that they need it to actually be able to either slow the progression of their disease or prevent it? So those are just some of the ways that we're looking at partnerships in a completely different way, because honestly, healthcare delivery is evolving quite quickly, not only because of COVID and telehealth, but really kind of systemically. And I think there's a real place for us to play in that.
So this is a panel, so I'm going to take the answer to the question in a different direction. And with my mind around the technology space, I'd like to think about how we can use those tools to better link together, obviously the scientific side, the glucose side overall, much more to the broader holistic picture of diet, nutrition, exercise, and so on. And when we think about the way, we will move going forward, with technology, yes, we'll have tools and devices as we have today, but I think an area where we can really do a lot more is around the information through the software we provide to people as well. And I think this is an area where we're starting out. I presented on a panel at the Diabetes Technology Society last November, and someone said, Mr. Boulton, that's all very, very well and good, but I want to see a lot more innovation around gaming, nudges, etc. in the software space. And I said, you're right. There's so much more we can do, because we all say better diet and exercise every day. How do we do it? We've got to find more fun, innovative ways to bring this to people as well. So there we are. So it's one that we've got to work on. I'll be on it. Everyone will be on it. I think this is one we can really think, how can we bring this to the palm of the hand with the iPhones, etc., to help people make better decisions around this every day.
Yeah, Chris has said, I'm really glad you brought this topic up. I mean, it's we started out with a partnership on food. It's so much, as you know, part of the diabetes experience and how it can really affect people in so many ways. And what's in that food is a kind of a seminal question. People are asked a carb count, and it's impossible to know. So we got involved with a company called Neutrino in Israel, who has the world's largest food database. We wound up acquiring that technology. So now you get this really accurate information about what's in the food you're eating and consuming, which is interesting. But what's even more interesting about what they've been working on and what we're hoping to do to take technology to the next level here is they can tell with really good accuracy that you're about to eat. And then we have other technology, I think called ClueyBot, which can confirm that you're eating. So that's interesting, right? That these technologies. But what it can mean for patients is now the process of eating without having to pre-bolus or post-bolus or correct can be automated. We can make meal handling sort of automated without a whole bunch of scrolling through menus to pick out what did you eat and how did you eat it and doing a bunch of math and things. I mean, we're not there yet. We're working on it, but it's amazing how you can try to make this go away to a greater degree and give more independence back to patients by taking on one of the biggest, things that moves things around. So it started as partnership, and now it's become part of our strategy and what we're trying to do and what we're trying to deliver and the value we're creating.
Yeah, I think there is a lot of power to that. Sometimes we don't necessarily want all the power all the time, but I can say from having this information from time in range, and there's ways of getting time in range, if you're on blood glucose monitoring, kind of results in range. It's really good to see how much of the time, I'm above the 180. Like I said, I don't always want to see it, but it really helps me kind of get back into where do I want to be? And I know that is the benefit to many, many patients. So let's see, I'm not positive, but Kiersten, did you want to, I heard before the panel that you had a question for Chris. Is that right? Is now a good time? Should we?
Yeah, sure. I'm going to ask you a whole bunch of hard questions, Chris. No, I'm just joking. But, I just thought it'd be kind of cool. One of the things that I've read about in the news lately, and one of the things that we kind of have touched on here, but haven't really truly addressed, is affordability of medicines for patients. And so I thought it was quite cool to see that the government announced lower out-of-pocket insulin cost and as part of the Part D, the Medicare Part D program. So just wondering from your perspective as an insulin manufacturer, what does that mean for you and how is that working?
So was that your hard question or easy question for me?
That was the easy one. Wait until you see the next one.
Thank you, Kiersten, for that. So, firstly, looking in these challenging times, I'm very proud of what my company is doing, and I know peers in the industry, we're all very proud of how pharmaceutical companies are stepping forward and being very relevant in society. And a little bit in my own company, whether it's development of vaccines, whether it's about doing trials on unknown products to help with COVID or diagnostic, etc. And insulin affordability is one more piece of that, where I'm very proud of what we are doing in this space. It's not a new topic, as we know. It's one that's been around for a long time, and at the same time, it's something that Sanofi has very proactively taken steps to address over time. So on the Part D senior savings model, a couple of things to say. Firstly, this was a voluntary choice of Sanofi to go into this. We recognize when we looked at the various populations that are served, whether you have commercial insurance, you have copay overall. We had a program, for people uninsured overall, where they can cash for $99 per month. They can get access to our medicines with very good utilization of that program. We recognize overall from the Medicare perspective, there's some things we could do to serve that population. So again, by working with all the industry manufacturers, everyone has opted in, which is great to see. But critically, the plans themselves have also opted in to be part of this. And I think in these challenging times, and this is a message I said earlier on around, we have to come together, whatever your background in the diabetes community, and work together. And solutions only work if everyone takes their fair share. And this is not about asking one person or one organization to take more share than another. So there's a little bit of the trust in there. We've all been brought together to step in and try and do something to keep the out-of-pocket levels for people in Medicare Part D low and throughout the period. So I think it's a great initiative. And Kelly, I know you're always on me for some numbers overall around the utilization of our programs. So a couple of them for you, just to sort of show how they've been accepted into the community overall. So for our insulin value savings program, we had 50,000 usages of the program in 2019, and between January and April this year, 28,000 usages as well. So with a hint, maybe a little bit more usage more recently. We've had a good enrollment into our temporary access program, which is helping people with an urgent change of circumstance. And with our patient assistance program for people on low income, in 2019, we had over 100,000 people participate in that program. So I hope you can agree with us that we're proud of what we're doing. It's unfortunate, some of these situations, but again, I'd like to say we're doing what we can as an industry to recognize, clearly in this point, a political topic, but also a patient and affordability topic, and demonstrating as a company, as a business, as an industry, we're doing what we can to support this space as well.
Yeah, we love hearing the numbers because we, then we can track. I mean, just hearing the numbers that you've done in the first quarter here, obviously you're annualizing at a lot higher rate even than last year. I also just want to salute Sanofi. You guys were the first ones who said, let's make this a monthly fee and let's not have a dosing tax. You know, historically, people with diabetes who took more insulin had to pay more, which doesn't make sense at all. Yeah, so we love seeing where those are going. You can also go to diatribe.org/access, and you can look at a lot more writing and about the different pieces about access, because we would really want to see the commercial payers now follow that leadership that we're seeing with Medicare. We also just know that there's many more people who would benefit from taking insulin, and not everybody is taking the right dose. And I know a lot of your work on that integration front, as you spoke to, Chris, is working on that. Do you have any questions for any of the panelists, Chris?
Well, it's hotting up now, isn't it? We're getting into the questions. So, I mean, Sean, firstly, you know, my daughter is on a Medtronic pump, and she's also on a Freestyle Libre. And I always say to my friends at Abbott, I thank them for what they've done for my family with the availability of the Freestyle Libre. And I'll say the same to you. Firstly, thank you for everything you do with your company as well for changing her life overall. And my question is both a professional and a personal one. You know, I'm always very interested to hear the work. I heard Boris Kovachev's work at the DTS last year around development around the artificial pancreas, and again, some of the great data that came out late last year. So, of course, back to the question of the technology and, of course, the time to access. How long should we wait until this wonderful technology starts to become something which is accessible for families like mine?
Yeah. Well, thanks for the question, Chris. And you know, as you know, diabetes is such a personal experience for a patient and for a parent, and we can do all kinds of things with technologies that can you know help them manage their disease differently. And that choice that they make about how to do that is important. But there's a lot of education, as we've talked about, and understanding that has to get there. So it goes, you know, we're trying to figure out how do we meet patients where they are, and how do we get them to where they want to go, or even let them know where they can go along the way. So I think that, you know, as we work on technology solutions, one of the things that's been driving you know, this is, you know, somebody to do just this much more to get something more. Where disease already asks so much of you is a problem, right? And then there's trust things. Do people trust the technologies that they wear on their belt? Do they want the world to see them? You know, I think what our goal is really to try to deeply understand the needs for people and be able to provide the right solution for them. And they can move, right? They can move from one solution to another solution as they get more control or comfort. But you know, it's, as you know, you've gone through a range of emotions yourself, I'm sure, from the time of diagnosis to, you know, fear of maybe your daughter going into the world on her own without your ability to help her. And I think that's really what we're trying to drive for solutions. And we wrap them up in technologies, and sometimes we get too wrapped up in technology and we forget about the human element. This has to be part of your lifestyle and your goals. And that's what we're trying to do with technology, is to make it invisible.
You know, you get to choose now, Sean. If you have a question back to Chris, a question for Kiersten, or we can keep moving. We got a lot of
these questions I'd love to get to, but Chris, are you wearing shorts? Just wondering. I am.
I'm not.
I'm doing the jeans look today. So, but I did put a shirt on for you, Sean. So there we are. Working from home, there are many benefits.
Yeah.
I wanted to say we're going to keep moving to audience questions. I think Divya has some that maybe about the polls that she might go to next. We're going to keep coming back to the audience questions. I wanted to say there was a really great one about reimbursement and how that cuts across ethnic lines. I actually think there is also so much on privacy. I'm actually not sure that they can get the data to that. We're going to come back with some of these questions once we figure that out. I know, like, there's so much about, like, the companies actually don't even know who buys their work, so we're gonna get a list that we'll come back to, so we get some of that for sure. That was to Chris out there, but Divya, should I turn it back to you?
Kelly. We'd love to talk a little bit about what the future looks like in our ideal world. So Chris, maybe we can start with you. What is being enabled with connected care, integrated care, and how far can we go with those tools?
Yeah, thank you, Divya. An area I'm passionate about, and I think I start off by saying, we're in a very special time just now. I mean, I think people have had the ambition for this space for a long time, but I think only now is the technology getting to the point of readiness, practicability, approvability, and ongoing maintenance that we can start to bring all the pieces together. And back to this sort of partnerships point, I'm very excited by this heady mix of sort of the traditional pharma company, say the insulin company like mine, the device company like Sean's overall, and then these sort of really exciting tech companies coming through with lots of innovation and different approaches, and really bringing together the sort of the devices, the hardware, with the software, and all of the things we can get out of that as we go forward. So I think it's a really exciting time. I think if you study this area closely, you will know there's lots of promises of new launches over the next year or so. And Sanofi is one of those companies saying we're going to bring connected ecosystems, forward in the next 12 months or so. And what does that look like? I mean, we have this pump at the moment, and we have the CGM connection. But what if you're not on a pump? This is where we can start to bring connected insulin pens forward, where you can, for the first time, bring together your continuous glucose monitoring data and your insulin dose recording data, and then you can start to look at that sensitivity between both the insulin you've taken and, of course, the glucose effect. Now, that is great if you are a person with diabetes managing your condition 24/7. It's also great for the HCP when they can step back and look at the longer term. It's also, by the way, great for payers. Back to that question around value-based pricing. If you can look at this data in totality and understand what works, what outcomes you can improve, and we've seen from some of the digital technologies, some of the A1C improvements we're seeing, and indeed some of our own Sanofi programs have shown A1C drops greater than 1.5% in the My Dose Coach program. This data is almost unbelievable, but actually it is believable because it's real life. You're taking people with good medicines, you're giving them good education, you're giving them the right tools, and overall you're getting this experience. And so what can we hope for the future? I think we will have this hardware that I've mentioned. You have the CGM, you have the pumps, you have the connected pens. But as I said, I think where you'll see the real move over the next few years is around this software, this decision support. And then we start to bring in all of these things we see in our lives every day around all the algorithms, the next best action, predictive technology, and you're going to get a lot more nudges and suggestions around what your next step is. Either it does it automatically for you, like in the artificial pancreas, or it's going to be something where there's a suggestion to you in a more open loop approach. So this is coming. I take the words from my question I got back at the GTS. So I think we can start to think about some of the game theories and all the other pieces. And I think there's a lot of clever science going on around these algorithm development, again, which really bring all this together in terms of taking a lot of the broader inputs into better management of our diabetes. So I think that's the excitement for the technology and where we will go. A bit back to my question to Sean, I think where we want it to be is this stuff is accessible, it becomes mainstream, it becomes how we do medicine. And again, as a company that's manufactured insulin for 100 years, we want to make sure we bring in this sort of support alongside great medicines. And it's just, we know this. Great management is what you need alongside great medicines to make sure we better help people living with diabetes. So that's a little bit my future. There are many other things I want in the next 5 years, but maybe I'll start with that as some of the things a little bit inside of our control, of how we can bring it back to diabetes over the next few years.
Yeah, I think you make such a great point, Chris, about how technology can really create these windows and insights for patients, as well as the provider side. A lot of what we're working on we have today system software, we call it called CareLink, and it gives you insulin and CGM data for a 2-week window. You get to look at it and see what's happening. But there's some challenges with that. You've got to upload your data, and then if you're doing that in the doctor's office, you have to go plug in, upload. It takes time away from their workflow. Patients can do it themselves. There's a personalized version of it that can work. But we're moving to that being automatic in the cloud. It gets uploaded. And then from there, not all healthcare providers are created equal, unfortunately. Some of the insights that you can get from that information, what can you go do? How can you optimize the settings of that automated delivery system, for example? What other insights you might be able to derive? What questions can you ask from the profile? what can I know? We can really take the quality of care up while somebody's, challenged by either a busy waiting room full of patients they're trying to get through, or even if we're doing this through telemedicine, where it's a much more informed conversation where you're talking to the patient, you're looking at the data together, and it's a place where you can deliver better care. And I think it can be better, honestly. We've been doing it. Our own experience with this has been moving to remote training, where we've got to take patients, teach them how to get onto pump therapy, and we've moved to that in a virtual world, and the satisfaction rate is higher than in-person visits. And we measure that with a satisfaction rate and net promoter score. And people are getting to their glycemic control faster, which is kind of fascinating, right? Where you've got this opportunity to make things better by leveraging technology, but don't make technology the kind of the driver, make it the enabler of better care. And I think that's really what we're trying to do.
I'm really interested in how, the doctors also obviously are short on time. A lot of this is very real. It's probably also even harder getting the first telehealth visits going for so many patients. But obviously it has the chance to make so many doctors themselves more efficient. I was just wondering, Sean, if you could say anything about just, systems like AGP, advanced glucose profile. I feel like even I get to work in this field, full time, and I only really started to understand that about a year ago. What are the possibilities there? And do you think that's part of what is hastening the improvement for people who do have access and do have engaged healthcare professionals who have the time?
Yeah. Now, Kelly, I think you're talking about people taking the time to understand, all these various things that can affect a patient. And at the end of that day, you get better glucose control because you have a better understanding of all the things that go into that. And patients, as we've talked about, need to understand that better themselves, and healthcare practitioners need to move beyond the kind of, you must have done something wrong attitude. You aren't counting your carbs, you aren't doing something that's good, and I think people feel dejected and blamed. But turn that around, and measurement is such a wonderful thing for making progress and to driving understanding. So a profile of glucose and understanding all those parameters, I think really helps, but it can also be pretty overwhelming depending on where you are. You're newly diagnosed and somebody's throwing all this jargon at you. It's daunting, right? So, and I think that to kind of demystify all of the scary stuff that has to happen for all those decisions and math and calculation and lifestyle change and interaction and just variation that happens day to day. No day's the same. Helping to understand that and break it down into things I can do, things I can see, things I can measure, I think gives control back to people who are struggling to understand it.
Thank you, Sean. One of our former colleagues, Adam Brown, wrote an article about how there are over 42 factors that affect blood sugar. And that's why time and range is truly the measurement of someone's lived experience. And so we had a question from Linda Marsh about how she's never seen an endocrinologist, and she works with a primary care physician and a diabetic nurse specialist. This is the standard of care for diabetes. This is what you deserve. And like we've been mentioning, a lot of doctors don't have the capacity to stay up to date on what's going on. And so we hope that you can take this conversation and bring it to those healthcare professionals and really use resources like diaTribe to learn about the tools that are out there for you. And primary care physicians and nurses, when they're supported and have the ability to access that education, they're ready to be partners with you. So on that soapbox, I would love to ask Kiersten what she thinks about the future from her purview.
Well, just sitting here listening, and this has been hugely educational for me. I think it goes back to where we started a little bit on how much of this comes back to the patient, whether it be the patient education, the patient understanding kind of where they are within their disease and what their measurements are, or the patient advocating with the physician because they may be dealing with multiple physicians. So I think that when you look to the future, we should not underestimate how important it is that we all, no matter what our our disease profile is or our health profile is, how important it is that we are educated on ourselves, we're educated on our disease state, and we embrace the technology that is there to help us, whether it be how we engage with health system, a physician, or our own kind of measures. And so I think there's a huge role that we have to, it's almost a mind shift around us as patients as to what's my role in this versus I go to a doctor, the doctor tells me something, and then I go pick up a medicine and the insurance company pays for it or doesn't pay for it, right? Like, it's now a much more integrated discussion. I have to actually be in control, whatever is my health status. And I think from a future perspective, we have to do more, because that's not necessarily the human psyche, and that's not necessarily the health system that many of us have been accustomed to over our lifetime. I think that's the first piece of it. And I think the second piece is, and I'm reading some of these chats, right? They're talking a little bit, we talk a lot about technology, a lot about digitizing our healthcare and the integrated network. But, there is still, when you talk about health disparities, there are health disparities from a socioeconomic perspective that influence what you eat. But then there's also, somebody said the digital haves and haves not, right? Like, not all technology is available to all people. And so I think that us continuing to work as to how do we make healthcare available to everybody in an affordable fashion, because that's really the only way that you can actually manage and potentially prevent disease and reduce the amount of people in America who have diabetes.
Thank you. Just to reiterate, we are not well as individuals unless our community is well. And so on that note, Chris, can you help us describe what you think a day in the life of a patient 5 years from now might look like for type 2, type 1, prediabetes, gestational?
If things go the way you all want them to go.
I think I can't firstly go past some of the things we said at the start of the call around helping those populations underserved, right? So maybe my point is not a single patient, but a bit more broad. I think there's a rallying call here that in 5 years' time, I think sort of inequality, we must do more. And maybe when we make our comments around education, all these other points, then clearly we need to think and do more to approach that. And hopefully that's something we can do something about much quicker than 5 years. So maybe that's something we can do in the shorter term. You've heard me mention a lot about technology, and I hope we could dream a little bit around what that future looks like and some of the things we can look forward to. I know we all get a little bit scared about what's listening to us on our devices and what they hear and what they do. But again, I think this wraparound predictive technology is going to be something that is our friend and can really help us a lot in the future as well. So I have high hopes with what the technology is going to bring to us. And my final point overall is, as a parent, I hope those exciting things are accessible to me and my family as well, to make our lives better. And for me, that's a bit about the hope as well, that actually there is a bright future, there is an optimistic future for many things, be that software and devices that can help every day a little bit easier and pass with more knowledge and help, and then some of the bigger ones we talked about with Sean around some of the access to things like the artificial pancreas in the future. So I'm holding on to that. And we'll always ask every time I see Sean and others around where we are on that, because I think, again, it shows that there is a good future. And I'm talking type 1, of course, a bright future there.
I want to go to Sean next. I mean, and I love hearing where you're going. And I think like more measurement and more metrics on knowing where we are. And we got to change like the quality, how quality is measured in healthcare systems. And I know that Sanofi has done a lot on that historically. So thank you. And I don't know, Sean or Kiersten, if you have thoughts on that, but more to Divya's question about like, what would you like to see the patient look like in 5 years?
Well, I guess in 5 years, what's a day in the life of a patient like? Hopefully they start with a better night. They're sleeping through the night and they're feeling good when they wake up. And then, really, I've talked about what we're trying to do with technology, but what we're trying to do is kind of make the everyday struggle of diabetes less, and just so you don't have to focus on your disease, you can focus on your life. And just don't there's so much that you have to worry about and to think about, and to live more would be just fantastic, right? And we can deliver that. And as I said, you got to do that in a way where the technology is friendly, accessible, doesn't interrupt your life, not any burdens. Trying to get to that to be, Chris, to your ask on an artificial pancreas, we're never good. Pancreas is a pretty incredible organ. Never replace all of it, but we're trying to restore people's health, and that's all we're trying to do. It's all this fancy technology, software, and pumps and sensors, and what we're trying to do is be a less, we're trying to make the beta cell come back, right? And you do that in a way that hopefully nobody has to worry about. That's our goal.
Yeah, and the automation, what can happen from this is so exciting. And I kind of feel like what all of you are doing is that, there's kind of automation in some of the combination therapies, especially at Sanofi. There's total automation in your best generation insulins, and the fact that you want everybody to get those is amazing. And Kiersten, my God, like you've talked a lot about that already, and what people might dream about on the complications front. Do you want to say anything more about the patients and what you want patients to be able to look forward to 5 years from now?
I know we're almost at the end of time, so I guess the only thing that I would like to say is that wouldn't it be cool between organizations like Chris's and Sean's and mine that we actually see the amount of diabetes in our country go down? And I think that what I've taken away from this call is that there is a significant amount of commitment and hope for the future on what that could look like, and why I think it's possible that we could actually see a decline in diabetes, and then therefore the complications like cardiovascular and renal disease that go along with them.
Yeah, absolutely a dream. I would say this one we might have to ask you to do a lightning round answer. But just to end, Divya and I really wanted to know, what advice do you have for all of us as we consider our role, in shaping the new reality of diabetes care? And I want to hear from Divya also last, after the leaders. Kiersten, can you start, and then Chris, and then Sean, please?
Well, I guess I would say that continuing to push the front on engaging in the conversation, and as diaTribe does this in your organizations, not only with healthcare professionals and organizations, but with patients, because I think that it does what Divya said. It keeps us healthy, not only as individuals but also as a community, and that is what is going to motivate the change.
Thank you. I think we've talked about many topics which are not a dream, but things we can do something about. From the more social and political through to the more technology based. So for all of us, it's in our control to do this. Huh? So I think as I say, disruption as we're in at the moment leads to innovation. It's our time to try and bring a lot of these things through and make it happen.
Kelly, you keep calling us the leaders of the field, and I don't know that that's right. There's so many people in this community that contribute to education, awareness, better health, whether that's through technology or just knowledge or advocacy. And we're all part of that fabric, and we have that responsibility to help make people's lives better. So I think we're all intrinsically linked one way or another, and together we're going to go farther.
Yeah, and to end, I'll say that when I look back to this moment in time, I want to be able to say that we all have moved past words and platitudes. We all listened well to our Black and Brown communities. We learned from what worked and what didn't work with COVID-19, and not only envisioned a better future, but made it happen. And so to make that happen, I think my parting advice would be to keep reminding yourself of the importance of a beginner's mindset. And if we can do that and are willing to challenge ourselves to grow a little bit more every day, I think that the possibilities are endless.
Well, I just want to make the point just to build on that, Divya. I heard an amazing speech the other day. It was from a young a young new doctor, Claire Wagner, and she was urging her classmates in a commencement address to reimagine normal, you know, to have the courage to make it so. And just to know that people weren't alone. And I think she was more talking to her classmates. But I love how we are hearing loud and clear that you know, industry wants even more to invest in the rest of the ecosystem working together. And I absolutely love hearing that on the part of diaTribe. So we're so grateful, everyone, that you took all the time today to learn from the leaders in the field and from Divya. Your questions and comments and interactions in this sessions were really inspiring, and another reminder of the power of the community. And again, we will be collecting any other questions that are out there and bringing answers back via diaTribe.org. Of course, a huge thank you to our phenomenal panelists, Chris and Sean and Kiersten, for really engaging discussion. Please, everybody, feel free to hang out on Hopin. You can go back to the sessions tab that's on the left-hand side of the screen, just to debrief some of the panel topics and connect with each other. I can't wait to talk to Sharice, our community manager, about some of this. I know I'm going straight to the sessions myself. You can also go to the expo hall. That's also on the left-hand side of the screen to check out some of the just incredible things available there. And again, more learning, more through video and so forth. We're going to try to keep these rooms over for longer than half an hour in case you're all deep in conversation. Divya and I are going to be there with you and the rest of our team. And thank you so much again to the team, especially Eliza Scholar, for making everything happen behind the scenes. And Divya was doing that as well from the panel. And we all know what Sharice does for our community, Sharice Shockley. And if you don't, come to the sessions. Join our newsletter if you haven't already at diatribe.org/join. Follow us on Twitter and Instagram. And, you know, we at diaTribe are just sending you a lot of love and power at this time. Thank you.